And we are going to start to talk about the specific malformations that can be recognized in the four-chamber view. And as Dr. Abu Hamid really nicely highlighted in his presentation, it's very important to take a look at the four-chamber view in the systematic manner. And here we present the checklist that we're actually using on an everyday basis in our department to describe all the structures that can be seen in the four-chamber view this way. And here we have an example of definitely abnormal four-chamber view. And here I would let you just to glance at that list for a moment and see what specific changes and which categories you can recognize here. So, and we can do it all together. So first of all, this fetus is in a breech presentation. So here is the baby's left side and this is the right side. And what really jumps on you right away that the heart is significantly enlarged. So the heart pretty much occupies the whole chest here. And as Dr. Abu Hamid pointed out in his talk that you're supposed to be able to fit 3 hearts of that size in the chest. And it's definitely not possible. I think it's actually very tight for just this one heart in that chest. So that we deal with cardiomegaly. So, and if you look very carefully into details, we can see that the heart is enlarged primarily because of the enlargement of the right atrium, and this is very specific for this abnormality. We also can see that the cardiac axis is deviated to the left, so if you will imagine the midline here, so the apex is definitely pointing to the left more than 65 degrees. We can see significant discrepancy in size between the left and right side of the heart, and if you look at the size of the ventricles, we can see that the left ventricle is much bigger than the right ventricle. So the cavity of the right ventricle is just here near the apex. And we can see that we can visualize 2 separate EV valves here and here, but the tricuspid valve looks very abnormal. We can see that in four-chamber view, we usually can visualize the septal and the anterior leaflet of the tricuspid valve, and the anterior leaflet has that sail-like appearance, and the septal leaflet actually is very short and attached to the septum to the very short subvalvular structures. So this valve is definitely abnormal. If you look very carefully at the septum, we will be able to see the VSD, and then this altogether makes this four-chamber view abnormal. So if you perform screening and don't really have time to look into details, this is the time to raise the red flag and send this patient for detailed assessment of fetal echocardiography. But this is just the example how you can work through the list and the checklist and utilize that to describe the changes in the four-chamber view. So in our diagnosis, I think that you all got that. This is the Epstein anomaly, and this is the anomaly that specifically affects the development of the tricuspid valve. And there are pretty much 3 things happening with the tricuspid valve. First of all, that septal leaflet shows some degree of the displacement towards the apex, and sometimes that displacement is very significant, sometimes it's minimal. But also keep in mind that not just septal, but the posterior leaflet can be displaced, and this, what you cannot really see in the four-chamber view. So all the leaflets are dysplastic, as we mentioned. The anterior leaflet is usually elongated and the septal leaflet is short. So that results in significant abnormality of the function of the valve, and that usually associated with the tricuspid regurgitation. And the other very specific process that is happening because of the displacement of the septal leaflet of the tricuspid valve, the part that anatomically belongs to the right atrium becomes physiologically and hemodynamically a part of the right atrium, and that process is actually called the atrialization, so that the portion of the right ventricle becomes the portion of the right atrium. So that's why when we looked at the cardiomegaly here, we were able to see such a dramatic enlargement of the right atrium. So the cardiomegaly is very common. Severe tricuspid regurgitation or regurgitation of any sort is also very common, that contribute over time to even more enlargement of the heart. And then we can observe some concomitant malformations, including the ventricular septal defect that may be observed in 15% of cases, and this is what happened in our case. And also the right ventricular outflow tract obstruction, almost the pulmonary atresia. This is also very common finding. So let's take a look at this heart once again and apply color Doppler. So what the color Doppler can highlight for us that the jet of the tricuspid regurgitation starts pretty deep in the ventricle. So this is pretty much indicates that the posterior leaflet is very much displaced towards the apex. So if we do the 3D reconstruction of the, or use the 3D imaging, so we can clearly visualize the place of the insertion of the septal leaflet of the tricuspid valve, and you can see that in this case it was significant displacement. And also if you look at the area of the right atrium, you can see that this pretty much equals the rest of the size of the heart, so that the enlargement of the right side is very significant. But not all the patients with the Epstein anomaly are the same. Here you can see the most favorable case that you may diagnose, and sometimes it actually can be misdiagnosed. So this patient was referred to the primary diagnosis or suspected diagnosis of tricuspid atresia. And the reason why, because it seems like this right ventricle is very, very small. Indeed, if you look very carefully, you can see that this is the attachment of the septal leaflet of the tricuspid valve, and this is significant displacement that demonstrated here, but application of the color Doppler demonstrates no tricuspid insufficiency, which is great. That's why the right atrium is not really enlarged. This is not very often seen in the case of the Epstein anomaly, but this is definitely something that improves the prognosis dramatically, because those babies, they do just fine. You can see that there is no evidence of the cardiomegaly, and this is the potential survivor with a very good outcome. So what is on the other side of the spectrum? This is this malformation in this case. So we can see that the heart is significantly enlarged. We can see that despite the fact that the ventricle is relatively large, we have a lot of regurgitation, not just on the tricuspid valve, but also on the mitral valve, which is also very not really good thing to see. And of course, the enlargement of the heart reflects not just a poor cardiac function. That large heart may affect the development of the lung, and you can see how little lung tissue is left here, and this fetus is just 25 weeks. So here we can expect that later on we will have the baby this significant compromise of respiratory function after birth that also will contribute to the poor pregnancy outcome. So this is like the other side of the spectrum. So what are the other malformations that you can observe looking at the tricuspid valve? So this is definitely very abnormal tricuspid valve. You cannot really see any displacement, but if you look at the leaflets, you can see how long they are, how thickened they are, and they are really dysplastic, prolapsing towards the enlarged right atrium. Then you see something like that, pay attention to the appearance of the other AV valves. And you can see that the mitral valve is kind of abnormal as well, not that dramatically like tricuspid. And this fetus has the trisomy 13, so then you see the multi-valve dysplasia. This is something that is very specific, and the first thing that you can think about is the genetic malformation. So the genetics counseling would be definitely recommended here. And this is the extreme case of the tricuspid dysplasia at 34 weeks of pregnancy. And let's go through this case. Of course, we have a very enlarged heart. We have very dysplastic valve. We have very long anterior leaflet. The septal leaflet hardly moving because it's fixed to the interventricular septum. They have the relatively large foramen valley. But my question to you, what is this thing is kind of moving in there? Right? It's very often finding to see the Chiari network, which is the structure that belongs embryologically to the formation of the coronary sinus, and pretty much this is something that develops and attached to the Tibiesian valve that sometimes can be seen on the normal heart. So, but this structure is basically a very thin fenestrated membrane that can be observed in many cases of the tricuspid dysplasia in Epstein anomaly, and see in this case it's even protruding through the tricuspid valve. So this is something that is a really interesting finding and should be distinguished from just foramen valley. So if we talk about the prognosis in this case, it's really poor, and unfortunately this baby was born with Apgar's 110, because as you can clearly visualize, this baby developed a very severe form of pulmonary hypoplasia, so, and that pretty much limits the survival of those kids. So this is another example, and here we are talking about the secondary changes of the heart, and in particular right side of the heart. And so the baby has very severe malformation. This is the heart is in the right chest. We have diaphragmatic hernia, the abdominal content, including the bowel and the stomach up. This is the right lung. So this is not really great situation in general, but we were surprised to see the enlargement of the right side of the heart. So then you see that, you look at the leaflets, they look kind of okay, but you want to see and figure it out why this right side of the heart has such a abnormal flow and why this tricuspid regurg is really caused by. So then you're looking for potential reasons, and here we can clearly visualize the dilation of the inferior vena cava, and this is the answer here. Then you're looking at the bladder. Here you can see the umbilical artery on each side of the bladder, but also you can see the umbilical vein on the side of the bladder as well. So, and as shown here, you can visualize that this is a very rare malformation where the umbilical vein, instead of going through the liver and giving ductus venosus and connecting to the portal vein system, so indeed curves down and joins the iliac vein, and that iliac vein connects to the IVC. So in this case, we have a genesis of the ductus venosus, extrahepatic course of the umbilical vein that basically causes the volume overload for this heart, and this is why that tricuspid valve has such a significant amount of the regurgitation. So, and this is over time develops to a really bad situation, to a really non-survival situation, because we have in the third trimester, this is all what left from the lung tissue for this baby, so that the appropriate counseling should be provided here. So tricuspid dysplasia, or like sometimes our colleagues from Children's Hospital call it the Epsteinoid tricuspid valve. I really like that term because, you know, there is a lot of similarities between the Epstein anomaly and the tricuspid dysplasia. So that can be diagnosed in the first trimester, especially then we are doing the detailed assessment now. And this is how it can be done. And of course, that associates with a very poor outcome, especially if you see the evidence of the fetal hydrops, like in this case. So, and pretty much everything that we discussed so far, looking at the images in the second and the third trimester, can be seen as early as 14 weeks gestation as this fetus is. So you can see the enlargement of the heart, deviation of the axis to the left, significant enlargement of the right atrium, and a lot of regurgitation that can be seen on the still images, not just in color Doppler, but in the spectral Doppler as well. So overall, there are lots of papers and data out there that shows what's the outcome and how to predict the outcome. Then we deal with the cases of the tricuspid dysplasia and Epstein anomaly. So, and this is the multi-center study published recently that included 243 fetuses from 23 centers around US and Canada. And here you can see that that study showed pretty much the same data that was published before, that the overall prenatal mortality or survival is about 50%. So, and they also found that independent predictors of the mortality at the time of the diagnosis was the diagnosis prior to the 32 weeks gestation, the measurement of the tricuspid valve annulus, evidence of the pulmonary regurgitation, and presence of pericardial effusion as the early marker of the development of the fetal hydrops. So this is very interesting data. So what we can do about it? It was a very interesting paper that published a couple years ago that potentially, a kind of pilot study again, included 23 mothers who received the non-steroid anti-inflammatory drugs, trying to prevent the development of the very specific changes in the circulation, because in many fetuses, the tricuspid dysplasia and Epstein anomaly, you will see that the right ventricle provides very ineffective blood injection to the pulmonary artery so that you can see the reverse in the ductus arteriosus. So as we all know, this type of drugs, they pretty much result in the constriction of the ductus arteriosus that potentially may improve the condition and the circulation for those fetuses, even though this is something that needs to be proven in the larger studies, but I thought that that was very interesting publication to look into. So, and we are moving to another case and another pathology that affect the right side of the heart. And now I would like to ask the question, which heart you want to be, the one on the left or the one on the right? Right? So like this is pretty much, I think, that what you need to do, then you look at the four-chamber view, you need to have, it's pretty obvious that you don't want to be the one on the left, right? So that you need to have this reference image kind of imprinted in your head, and that you will compare this like anything that you see in the four-chamber view, like here. So, and we can recognize certain parameters that help us to describe the changes that we can see here. And we are going to take pretty much the same checklist to do so. So first of all, the axis is abnormal, but in this case it's deviated not left, it's deviated right. So if you kind of imagine that this is the midline of the chest and this is the line that traces the interventricular septum, the angle is very narrow, so the axis is deviated right. So then you look at the size of the ventricles and you can see that the right is definitely smaller than the left, and it doesn't really contribute anything to the formation of the apex of the heart. Then we look at the AV valves, we can see that the mitral valve opens and closes, but the tricuspid valve doesn't really show any evidence of movement. It's echogenic, and basically there is no valve or leaflets that the opening and closing is just the echogenic structure like membrane. And then we can see the teeny tiny hole here, so that corresponds to inlet VSD. And so that pretty much describes the findings that we have here. So the diagnosis that we can already suspect, this is the tricuspid atresia. So that we have no, that the tricuspid valve is atretic, the right ventricle is hypoplastic, and if you look at the pulmonary artery and the great vessels, the most common situation that we will find out that would be stenosis, atresia, stenosis or atresia of the pulmonary valve. We're always going to have the VSD in this pathology, and in majority of the cases, the obstruction of the pulmonary artery, we will be able to observe reversed or bidirectional flow via ductus arteriosus. So let's take a look at the other case. So this is the same appearance of the four-chamber view as the baby in the vertex presentation. This is left, this is right, and you can clearly see that there is a big left ventricle, there is no movement of the tricuspid valve, there is a VSD teeny tiny chamber, and the color Doppler helps to pretty much confirm the same findings, showing the normal inflow on the left and no flow on the right. So, but indeed, the tricuspid atresia is a very, very diverse and huge group of the cardiac anomalies. And what makes the variety of those anomalies? Actually, the connection of the ventricles and the great vessels. So in 97%, the connection could be concordant in terms of the atria and the ventricles, so that the left atrium corresponds to the left ventricle. But in about 3%, the atrioventricular connection could be discordant. So this is an example here where we have the left, the baby is in the bridge presentation, so we have the left atrium, right atrium, we have the left ventricle that connected to the left to the right atrium anatomically. We have a teeny tiny chamber here and no tricuspid valve, because the valve pretty much determines the morphology of the ventricle and belongs to the ventricle. So we have the left atrium, right ventricle, left ventricle, and the right atrium. So that's altogether very rare, but it's very important to keep in mind that the rudimentary ventricle may not be really connected to the appropriate atrium. And then we look at the connection of the ventricles and the great vessels, or ventricular arterial connection. The most common variant that we discussed was this one. So then we have the VSD, it may vary in size, and then we have some degree of pulmonary stenosis. A half of cases, the tricuspid atresia will demonstrate that. But also you may have the complete atresia of the pulmonary valve, or you may have a normal appearance of the pulmonary valve. Usually in this case, the connection of the big left ventricle ventricle, the rudimentary right ventricle, is going to be relatively large. So that pretty much determines how well the pulmonary artery is going to be developed. And then it may get even more interesting because the vessels could be discordantly connected to the ventricles, and that could be a situation of transposition. So this way we will also have some abnormal relationship of the great vessels. And I'm not going to show you a lot of pictures here because about kind of truncal anomalies and relationship of the great vessels we will talk the whole day tomorrow. But it's important to keep in mind that the tricuspid atresia, every single time then you suspect it in the four-chamber view, then you have to take the whole different step to determine how the great vessels are connected to the ventricles, how the ventricles are connected to the atria, and how really, the blood flow occur. So, and we had the one case, I think, in 10 years where the tricuspid atresia was associated with the common arterial trunk. It's very rare, but again, keep in mind that it could be the relationship of the great vessels and their development, could be anything. So once you made the diagnosis of tricuspid atresia at the level of the four-chamber view, so then you just need to describe the rest looking at the outflow tracts. So pulmonary stenosis. This is another malformation, quite tricky to diagnose prenatally because if this is a relatively mild variant, so can be missed in the second trimester and may become more visible in the later of pregnancy. So pulmonary stenosis is pretty much characterized by the obstruction of the pulmonary artery. Keep in mind that it could occur at the level of the valve, below the valve, or above the valve, but most of the time the isolated pulmonary valve stenosis occur right at the level of the valve. And it's important to keep in mind that the lesion may progress over time. So that's why if you suspected that the leaflets look a little bit bright, the flow is a little bit high velocity, it's very critical to bring these patients back, in particular in the third trimester, for further evaluation. So, and here is again our two pictures, so the one on the left, the one on the right. So here it's more difficult probably to get the differences, but we will try. So what is really striking here, that the right ventricle and the myocardium of the right ventricle looks very, very thickened. So this is hypertrophy. And what else we can observe, that the septum kind of bowing towards the left ventricle, because usually the septum doesn't really move that much and doesn't show a lot of excursion on the fetus because of the blood pressure being pretty much the same. So once you have a little bit elevated blood pressure, significantly elevated blood pressure in the right chamber, so then it starts bowing towards the left ventricle. And this is also a very important marker to take a look at when you do your screening exam. So, four-chamber view characteristics and the settings of the pulmonary stenosis usually allow you to see the right ventricular hypertrophy of different degree, bulging of the intraventricular septum towards the left ventricle. So we will see that the cavity of the right ventricle looks very small, right? So that even though the size overall looks kind of okay, so the leaflets could be echogenic. They may not move that really freely in comparing to the left side of the heart. And then we will see sometimes dilation of the right atrium, in particular if we have significant amount of the tricuspid regurgitation, as we can see on this fetus. And you can see the bowing of the septum is more obvious. In this case, then you're moving a little bit from the apical four-chamber view to more axial orientation of that. And of course, color Doppler and the spectral Doppler are very critical to confirm the presence of the tricuspid regurgitation. So RVOT, this is a diagnostic view. Here we will see that the abnormal excursion of the leaflets of the pulmonary valve. See, they kind of stick together and not really disappearing in systole, then the valve should be completely open. We can see some degree of the dilation, poststenotic dilation of the pulmonary artery as well. So in color Doppler allows to visualize the turbulent flow. Sometimes we can see also some degree of the regurgitation, but definitely we can visualize how tiny the opening is of this valve, and color demonstrate that very clearly. So the spectral Doppler, looking at the velocity characteristics, once you get the velocity over 150 and it's getting a little bit higher, so you need to monitor that very closely. For this case, we got the velocity over 200 centimeters per per second, which was really consistent with very significant stenosis. So the free vessel and trachea view can demonstrate the same thing, so the discrepancy in size where the pulmonary artery would look significantly larger than the aorta. And of course, application of the color Doppler in the settings of the significant obstruction of the pulmonary valve and RVOT often would demonstrate the reversal flow through the ductus arteriosus or bidirectional flow, as you can see here. So the other very common finding, especially with the new equipment, is that you can really see the coronary circulation, and you can see that little channels that should not be misinterpreted as the ventricular septal defects. This is the sinusoids or like coronary fistulas that can be visualized, and if we look at the blood flow in the spectrodoppler, it looks completely different from what we would see in just regular muscular VSD. So that can be observed in the more significant obstructions such as the pulmonary atresia with intact septum. But in the critical pulmonary stenosis, this is something that you can see too. And another thing that helps you to make the diagnosis and also should not be misinterpreted in the obstetrical world, that many of the patients with obstructive lesions of the right heart, they may demonstrate the abnormal flow in the ductus venosus, showing the reversal of the A wave of the spectrum. So this pretty much due to the physiology and hemodynamic changes of the heart anomaly and has nothing to do to the baby's well-being. So you should not really consider that baby, even if this is the very small for gestational age, growth-restricted baby, if the other parameters of the Doppler in the umbilical artery and MCA are normal, so this finding should not really make you to make any judgment from the obstetrical standpoint. So even though the obstruction of the valve, like stenosis, is more common, the valve could be really dysplastic. And this is the very rare example. Then we have the significant stenosis and insufficiency, 2 jets of insufficiency, actually. And this should be distinguished from the tetralogy of Fallot settings with the absent pulmonary valve. So this fetus is the very dysplastic pulmonary valve and the Noonan syndrome. So in here you can see that looks pretty similar to the previous case, but if we apply spectral Doppler, we can really see that back and forth flow. And the very different situation here from the tetralogy of Fallot case, that usually those babies have a genesis of the ductus arteriosus. These babies, they have normal ductus arteriosus that prevents the significant dilation of the pulmonary arteries. And technologically, it's very reasonable to turn on, instead of pulse wave Doppler, that you can go up to PRF pretty high. Here is 12, but still you cannot get rid of the aliasing. So if you go to the continuous Doppler, you can pretty much achieve the PRF of 33 that clearly would demonstrate the degree of the stenosis and insufficiency on that valve. So the pulmonary stenosis can progressively get worse in utero and result in pretty much nearly atresia. And the next anomaly that we are going to talk about, not necessarily progression of the initial stenosis, but also a kind of more critical situation with the obstruction of the right ventricular outflow tract. This is pulmonary atresia with intact interventricular septum. And here is again 2 our 4-chamber views. We know that this one is normal and this one is abnormal, and you can see how small the cavity of the right ventricle is, and that pretty much just a little sac that a very significant myocardial hypertrophy. And color would demonstrate here just very abnormal flow, so you can see the inflow on the left side and pretty much nothing on the right side. So think about this pathology as the opposite to the hypoplastic left heart syndrome. So we usually don't call it hypoplastic right heart syndrome, more likely pulmonary atresia with intact ventricular septum, but you may think like the opposite on the right side, then you will be right, because this is how that ventricle would look late in the pregnancy, and you can see that it's a very poor contractility, that the leaflets of the tricuspid valve are there, but they are hardly moving because this ventricle is not really able to pump the blood anywhere outside that cavity. And as I mentioned before, presence of that multiple sinusoids is very common, and sometimes it's easier to get the short axis view just to see how that coronary circulation, how abnormal it is in those babies. So the 3-vessel and trachea view will demonstrate the different degree of the stenosis and hypoplasia of the pulmonary artery. You can see how teeny tiny the exit is here, and sometimes the only clue is just a reverse flow in the ductus arteriosus, so that in 2D you cannot really find the pulmonary artery. So this is another example of the pulmonary atresia, that intact septum. You can see that the valve is here. The pulmonary artery is not that much hypoplastic. The ventricle also not that much hypoplastic, but there is no flow, antegrade flow across the valve. And in the last few minutes, less than a minute, I'm going to show you the other very common finding that should be recognized, in particular in the third trimester. And I think that this is an increasing incidence of this pathology in the clinic. At least we definitely see that. So this is the obstruction or in utero constriction of the ductus arteriosus. And the changes that you can observe in this anomaly or this condition actually very similar to those that we discussed in the other situation than the right ventricle outflow tract is obstructed. So what we can see here, that on the ultrasound we will be able to find that the minimal flow across the ductus arteriosus with a very high velocity, or if we look at the specific index or pulsatility index, that can be significantly decreased. So what does it mean? So here is the patient who by herself decided to take Celebrex at 30 weeks gestation. And exactly the same day she had the fetal echocardiogram with the history of prior child born with a masculine VSD. So you can see that this is very, very abnormal flow in the ductus arteriosus, even though on the color Doppler you can see a little bit of the turbulence here. So the patient was advised not to do it again and brought back in 3 days, and you can see that this is perfect resolution of this situation. I think that many patients who are actually treated for preterm labor, the Anderson, even though we have a very strict protocol, but some babies can get more sensitive to that drug, and this is something that you can observe even if you administrate the drug not more than 72 hours. The good thing about that this is basically reversed. I mean, so you can just stop doing that, and that can be reversed. So, but again, it's very important to follow the protocol, and sometimes the patient going home, we do the ultrasound, and then we have the very specific changes in the heart. Sometimes you can see the kinking of the ductus arteriosus, and here you can see also significant obstruction with a very abnormal blood flow consistent with the restriction. And this is the very interesting case. So the patient has Williams syndrome, so the deletion in chromosome 7, and they are very sensitive. So the mom took Tylenol on Friday and presented for growth ultrasound on Monday. And on Friday, that was normal ductus arteriosus, and on Monday, you see nothing. So this is something that you really need to be careful. Definitely, you don't really have that many patients, but we had in our clinic like several of those who was extensively using Tylenol in the late third trimester of the pregnancy, and babies developed the constriction of the ductus arteriosus. So here you can see the cardiac remodeling and the sequence, what happens. Then you have the constriction or complete obliteration of the ductus arteriosus. Definitely we will see the enlargement of the right side of the heart, the bowing of the septum. So the same findings that we will see just in the pulmonary stenosis. And we can also observe the abnormal function of the right ventricle, the decreased contractility. We will be able to see the significant tricuspid regurgitation, and what's really important, the monophasic feeling of the right ventricle. And another striking finding that the patients with the constriction of the ductus arteriosus, they have a lot of coronary circulation that can be seen by just the regular color Doppler. So this is also kind of very specific for those patients. And those patients will also have the reverse flow in the ductus arteriosus and abnormal flow in the hepatic arteries and veins. So all those pathologies, they have some similarities, and And I hope that looking at the four-chamber view, you will utilize the checklist, and so you will not be able to miss them in the screening settings, so make the exact diagnosis that if you perform the fetal echocardiogram. Thank you very much for your attention.